Okay, and we are off. I'm going to redo much of the short burst of material that we covered the other day, just because some students weren't present. Also, my apologies, even though I had two computers going on, I was still having difficulties with showing things, particularly some of the slides and some of the videos in a very efficient way. So I'm trying to make up for that a bit by recording this. We talked about how that the largest number of mentally ill people who are in some sort of institutional setting are in prisons. We talked about how previously they would have been in state hospitals, typically for conditions like schizophrenia, which occur somewhere between, usually has its onset between 18 and 25. Young people would basically be checked into one of these hospitals. It wasn't very difficult to hold people there against their will, and they often lived there until they died. Many of these institutions have graveyards on their sites. I actually tried to find the one in Traverse City because the Traverse City Asylum is still, the buildings at least are still standing. They're not used as a hospital anymore. They're used as restaurants, little shops, and apartments. There is a section of the Traverse City graveyard, a graveyard in Traverse City, that is dedicated specifically to patients who were in the asylum at Traverse City and died there. The graves, unfortunately, are not kept up very well. Nowadays, if you want to find an institution that has a large number of people with psychiatric problems, the best place to go is a correctional facility. Figures I have seen range all over from lows of 25 to 30% of inmates having severe mental health problems. I saw a figure the other day that said 70%. Anyway, what has happened is that the wardens of state prisons have essentially become superintendents of a psychiatric facility. They're not too pleased with it. That's not what they signed up for. And for a number of reasons, probably prisons are not the best place for people with mental health problems, although one of the benefits is that they are likely to receive some basic level of treatment there, medication at least. And I'm going to post a relatively short, documentary on mentally ill prison. So when we look at abnormality, these are the big five. These are the various ways we've defined it. Abnormality as being something that's just rare, doesn't happen very often. In epidemiology, the study of diseases and symptoms, we usually consider a symptom to be significant or meaningful if it occurs in less than 10% of the population. Socially deviant, a violation of norms. Okay, you know, on one of Michigan's terribly cold winter days, somebody is running around outside in gym shorts and a tank top. That would be considered socially deviant. Alternatively, wearing your boxer shorts on your head would count as socially deviant. Anything that's a violation of norms. And some people have said, I'm sorry, what's happening? And let's cancel it. Okay, back to live action, I hope. Some people have said that we call people ill, mentally ill, if they are different from us. People who are too different from us bother us, make us uncomfortable. Therefore, one way to discount their perspective is to label them mentally ill. This was done in the old Soviet Union um, with people who were dissidents, people who spoke out against the government were labeled as mentally ill, delusional, and sent to psychiatric facilities. Often these were fairly intelligent people like journalists, college professors. But in that society, it was deemed deviant, against the norm, to speak out against the government. Subjective distress is something that most of us have experienced sometimes, and these are situations where outwardly no one would know that we're having a problem. Inwardly, we may be torturing ourselves. For example, if you have to give a talk in a class and you just hate public speaking, you feel like everybody's sitting there judging you, you go up there, you give your talk, you get through it, you sit down next to your friend and say, oh my God, that was just awful, wasn't it? And your friend says, I don't know what you're talking about. You did an okay job. Actually, you did a pretty good job. You go, oh, I just felt terrible. I wouldn't have known you felt terrible. So it's something you experience that people don't see. Impaired functioning, most definitions of mental illness, including those in the medical model, which is right below it, require that your functioning be impaired. Okay? What does that mean? Well, if you're seriously depressed and you've engaged in repeated self-harm, or you haven't gotten out of bed in 3 weeks, you've showered, that would count as impaired functioning. Not going to class, not showing up at your job, not being able to maintain basic hygiene, taking showers, taking baths, brushing your teeth, all that kind of stuff. And it's generally expected that young people, young adults, would either be going to school or working a job. If you're doing neither, that would be generally considered impaired functioning. And finally is the medical model, which views abnormal behavior as an illness with a diagnosis, diagnostic code, treatment of choice, everything that goes along with a medical diagnosis. So that conditions like schizophrenia, major depressive disorder are seen similarly, conceptually similarly to, say, strep throat or type 2 diabetes. Okay, statistical rarity. If you have a 12 to 18-month-old child and you take them to the doctor for their well child visit, typically they'll weigh the baby, they'll also measure their height, and they'll plot those figures on a little graph. If your child falls below the 10th percentile, and this graph is based upon what normal distribution of children's height and weight at that age, if your child falls below the 10th percentile, that is likely going to be a concern. And usually it happens because your child is not eating, taking in enough nutrition. Okay? And that is a condition we sometimes call failure to thrive syndrome. The only diagnosis that you'll find in our diagnostic manual that's based upon statistics and statistical rarity is what used to be called mental retardation. That term was abandoned, it was seen as derogatory, and was replaced by intellectual disability. I have borderline intellectual functioning up there. That would be people who are falling probably below the 5th or 6th percentile. To give a diagnosis of intellectual disability, it means you've got an IQ below 70, where 100 is the average. And that's about 2 to 3% of the population. But you have to keep in mind, when you're thinking about statistical rarity, that there are some highly valued traits in the population that are rare. Albert Einstein. Very, very few Albert Einsteins around. Despite the fact that he came up with the theory of relativity, he famously wrote to a student who was talking about how difficult he found math to be, wrote back to him and said, "Your difficulties in math are not nearly as severe as mine." We talked the other day about wanting to be Barbie. Is wanting to be Barbie a mental disorder? Well, it certainly is associated with repeated cosmetic surgeries, which probably have some risk associated with them. I think this woman has had about 30 of them. And she spends huge amounts of time, like hours, preparing her makeup when she is being Barbie. We mentioned also that she has gone as far as to have some ribs removed to match Barbie's proportions. This has been one of the criticisms of Barbie, that it really holds out an image, a body image for girls, little girls, that is frankly impossible to attain. You can't do crunches and look like that. It's just impossible to attain without something dramatic like surgery. And then I mentioned that there was a gentleman in Eastern Europe who also had a number of cosmetic surgeries and wanted to be Ken. Now, are these people just eccentric, or are they mentally ill? Is their functioning impaired? You could look at it both ways. Somebody who subjects themselves to multiple surgeries, and I have up there, Ken has had over 100. Somebody's had multiple surgeries, probably is doing something risky. Okay? Because every surgery has some degree of risk associated with it. On the other hand, is their functioning impaired? Well, if they're succeeding, meaning they get attention, they draw a salary, they're paid to appear at various functions as Barbie or Ken, it may not be associated with impaired functioning. Actually, it may be associated with improved functioning if you use how much money you earn as an index of how well you're functioning. So, back to IQ. This is a normal curve. This is how IQ is distributed in the population. Has an average IQ is 100. 68% of the population falls between 85 and 115. And you see that 95% of the population is between 70 and 130. When you're in the 70s, your IQ is called borderline. That's about maybe 5% or so of the population. And you can see that if you use intellectual disability, or in the old days, mental retardation, as the definition of abnormality, these are folks who fall in the lowest second percentile of the population. And this is typically based on a one-to-one standardized IQ test. And those IQ tests are mentioned in the recorded lecture on psychological testing. So one of the points I was trying to make is that statistical rarity doesn't work very well as a definition. Frankly, because these conditions are common and are probably becoming more common. You can see from that graph, that is not a, what shall we say, that is not a chart that's based upon specific diagnoses, but more based upon symptoms. If you use symptoms of psychological distress, certainly the majority of the population has experienced these at a significant level for some period of time in their life. So they're not statistically rare. That is the so-called Bible of psychiatry, and we'll be referring to that throughout the course, and I thought I should get this in early. This is generally accepted as the way that these conditions are defined. So, symptoms for major depressive disorder, you have to have 5, 9 symptoms. Excuse me. They must be present persistently for at least 2 weeks. And again, that is the formal definition of major depressive disorder. Um, this manual is now generally used throughout the world. It is, since the first version of it, the DSM-3, came out in the late 70s, it has really caught on. It lists specific symptoms. You usually don't have to have all of them. You usually have to have a certain number of them, and you have to have them for a certain period of time. Sometimes there is a symptom that must be present. So, for example, generalized anxiety disorder, a symptom that must be present is worry that is considered excessive. Generally speaking, people with generalized anxiety worry about things that we all worry about: our health, finances, schoolwork, our jobs, but the amount of worry is excessive. Okay, we have to have that. And each of these diagnoses in the book has a code, numerical code that goes with it. That's what your psychologist, psychiatrist, medical doctor would put on your insurance record, your medical record, and also on the insurance form. If you don't have a condition, if your symptoms don't fit um, one of these diagnoses that has a number associated with it, it's unlikely that the provider is going to get paid. But you can see that there are 297 disorders in there, and it's very, very likely that whatever problem you bring to your healthcare provider, we have a label for. So if you're a regular vapor, you've got nicotine dependence disorder. If you binge drink 4 or 5 beers on a Saturday night, maybe twice a month, you've got alcohol use disorder. If you broke up in a romantic relationship and were distressed for a while, meaning you had some difficulty eating, sleeping, mood wasn't the best, we have a label for you: adjustment disorder. So almost every kind of human emotional distress.
I hope this works. I got cut off. I hope it continues. um, Again, just to make the point, these things are not rare. By the time you are 22 or 23, about 45% of the population has met criteria for at least one mental health condition at some point in their life. It does not mean they have one then, but it means they have had one at some point by the time they're 20, 22 years old. Those are the prevalence rates. That means what percentage of the population has a condition now. That's called point prevalence. If you ask people if they've had the symptoms of one of these conditions in the past year and they have the full complement of symptoms to get a diagnosis, that would be called 1-year prevalence rates or 12-month prevalence rates. So the point of this is basically statistical rarity doesn't do a very good job of accounting for abnormal behavior in the sense of psychopathology, because these conditions are not rare and there's quite a bit of evidence that they're becoming more common. This is also a slide showing you the proportion of people, men and women, who have taken antidepressant medication. Those are those that are taking it right now, and you see it's for different years. Generally speaking, the proportion has gone up. I think the dip occurred. You'll see a dip around 2015. I think the dip occurred when there was a lot of attention being given to side effects and the possibility that antidepressant medication increased suicidal thinking. I can tell you what the status of that is now. Basically, it is possible that early on, when somebody starts taking an antidepressant like Zoloft or Prozac, that in the first couple of weeks, they may not experience a lot of benefit from it, and they may feel kind of jumpy. They may feel a little bit nauseous. And so I think that may contribute to an increase in suicidal thinking. However, it is not established that you're more likely to commit suicide if you're taking them. You may have suicidal thoughts, but that is different than actual suicidal behavior. And as I mentioned in class, depending on how you assess it, and you look at women between the ages of 15 and say 60, at least 30% or so of the US population of women has taken an antidepressant or is taking an antidepressant. Again, the point here is these conditions are not rare. Antidepressant medication is typically in the top 10 medications prescribed in the United States, along with those for high blood pressure and cholesterol. So I'm talking about prevalence and incidence. I want to give you sort of a quick overview of what those mean. Those are terms from epidemiology. Prevalence, as I mentioned before, is a number of cases or percentage of cases of a particular condition that is present now or in some specified time period, like the past year. We also talk about lifetime prevalence. Have you ever had these symptoms for a particular period of time? Again, for depression, 2 weeks. For generalized anxiety, where you have excessive worry, muscle tension, difficulty relaxing, difficulty focusing. If you have that group of symptoms and you have it persistently for 6 months, that's a diagnosis of generalized anxiety disorder. Okay. Incidence is a number of new cases in some time period. Now, we don't spend a whole bunch of time focusing on incidence, except in certain situations. For example, when countries become more westernized, the incidence of mental health conditions rises. Probably the best example has been in China. I taught in China for a bit and ended up studying this. And as China became more and more westernized and developed a more of a free market economy, while it's still a communist country, their economy is not as communist focused. It's not as tightly regulated as it used to be. And people have become, as you well know, millionaires in China, like the guy who runs Alibaba. As China has become more of a Western type society in terms of the economy, the rates of major depressive disorder have increased. That's an example. These again are just illustrations. Lifetime prevalence of major depressive disorder. You'll notice that it's about twice as common in women as men. That is a somewhat controversial but pretty consistent finding when you look at the rates of mental health problems, specifically major depressive disorder. You compare women and men. However, if we were to use alcohol abuse as the condition of choice and compared men and women, as you would imagine, it was going to be more common in men. Okay, social deviance. I'm going to do a little bit of this and then we will stop. Most adult disorders include some type of behavior that is socially deviant. Wanting to take a chainsaw to your wife's midriff, I think counts as social deviance. having conversations with Mickey Mouse and Donald Duck and believing they're right there talking to you, I think that counts as deviance. Making repeated suicide attempts, not getting out of bed, showering for a month, I think that is deviance. So most adult disorders do include some type of behavior that we would consider deviant. It doesn't follow norms. It doesn't follow what we expect. But you have to put that in a historical context. Long ago in the Dark Ages, when I was getting trained and dinosaurs were roaming the earth, we were taught this very interesting, allegedly practical finding that if you were evaluating a patient, say in an emergency room, for a mental health problem, and they had a tattoo, it was very likely that they met the criterion for what we call antisocial personality disorder. Now, I'm going to say this again and again in the course. Antisocial does not mean I don't like being with people. Antisocial personality is a label you'd usually apply to criminal behavior. Okay. At that time, that probably was a correct association. Today, with 20 to 30% of the population having a tattoo, that's no longer the case. Tattoos, I don't think, have much mental health meaning, period. However, back when they were rarer, they did. And there is Angelina Jolie, who has a number of interesting tattoos. Somewhere on her body is testimonial to one of her ex-spouses, Billy Bob Thornton. So is socially deviant behavior by itself mental illness, or does it depend on the context, the historical context, the social context? Think about that for just a minute. I'll show you a couple examples of behavior that raise questions in this regard. This is something that I have had to deal with as a clinical psychologist over the years, and that is evaluating people who have committed usually pedophilia, acting out sexually with a minor. And I've usually evaluated these folks in some sort of facility, be it a group home, maybe for the juvenile court. And I've been asked to make the prediction is if we let this person out, what's the likelihood they're going to reoffend? That is some respects difficult prediction to make. For example, I've worked in settings with young adults, and their preferred victims are young kids like preschool and early elementary school kids. And they've been in a facility where they didn't have any access to them. So they didn't sexually act out with kids. So if we send this person after 2 years in a facility out into the public, are they going to act out again with little kids? That's a very difficult prediction to make, since frankly, the best predictor of future behavior is past behavior. The more recent behavior, the better you can use it to predict. The best example is somebody who's aggressive. If they're beating up the nurses in an inpatient facility, what's the likelihood they're going to beat somebody up if you discharge them? I would imagine pretty high. Okay. If they've been aggressive 3 years ago and haven't been aggressive in the past several years, it's probably less likely that they would be aggressive, but under certain circumstances that may elicit it. Anyway, one of the big issues that has arisen with these gentlemen, these are both Catholic clergy. The guy on my left, who you see in sort of profile, is Father Geoghegan. Father Geoghegan was a priest in Massachusetts, was involved with boys. Can't remember the number of victims he had. He ended up being killed by another inmate in the penitentiary. The issue that has arisen in dealing with pedophiles has been, is this a mental illness that warrants treatment, or is it, frankly, immoral and harmful behavior? Period. The end. Having interviewed Catholic clergy myself who have engaged in this kind of behavior, one of the things that they often will report is they would say, I was in the presence of this little boy, he was an altar boy, something just came over me and I couldn't control it, and they talked about sexually acting out. Does that make it a mental illness? I don't have a ready response to you. I can tell you that these conditions are not readily treatable. The success rates, meaning that if you have somebody go through a treatment program for pedophilia, what's the likelihood they're going to reoffend? It's pretty high. It's probably over 60%. Okay, so the success rate of these programs is no higher than about 30 to 35%. Just to give you a comparison, the success rate of Prozac in treating depression is about 65 to 70%. So we're not very good at treating these conditions. Incidentally, as an aside, the treatment programs that are most effective are those that are run by prison systems. Again, I have treated these folks. I can't say that I have been terribly successful with them. And the settings that I was working with them in were more outpatient kind of settings. And frankly, that's not the best place to work with these folks. Okay, this is our last point. I'm gonna ask you to listen to a couple segments of a radio program, This American Life, which talks about the process by which homosexuality stopped being a mental disorder. That slide is not the best, but that little device up there is a shock box. And I'll tell you about my experience being trained with this. Shock box was a device that was used to classically condition, if you want to call it that, straight or heterosexual behavior. So the person looked at and these were usually adolescents, looked at a photo of if they were a guy, looked at a photo of a nude man. If they showed some kind of arousal, they got an electric shock. If they did not, they didn't get a shock. They were shown pictures of nude women. And if they showed some interest in them, they did not get shocked. Maybe they got some sort of reward, although I can't think of what that would be. Anyway, I have a series of slides, about the next 10 slides, are photos that deal with some of the key players and key historical changes that occurred in our view of homosexuality. And I would like you to listen to This American Life and go through these slides. You may need to bounce back and forth, and we will pick it up in class and talk about this bit. And then we will also go forward and talk about other definitions of abnormality.